So let's discuss CBT. First question is, distal end of humerus develops from how many centers? Choices are 2, 3, 4 and 5. To understand this, first we see the distal end of humerus. This is the picture of humerus showing various parts of the humerus. Now as we know, the ends they develop from the secondary centers, and lower end of humerus or the distal end of humerus, here we have the following centers. One is capitulum with lateral part of trochlea. The other is medial part of trochlea. One is for medial epicondyle, the other is for lateral epicondyle. So total we have 4 centers, and about 16th or 17th year the lateral epicondyle and both portion of articulating surfaces which have already joined, they unite with the body. So basically in 18th year the medial epicondyles, it will join to it. So correct answer to this question is 4. Now let's move to the next question. Tympanic plexus is present on anterior wall of medial wall, posterior wall of medial wall, medial wall of middle ear, lateral wall of middle ear. You see, anterior wall of middle ear, posterior wall of middle ear, medial wall and lateral wall of middle ear. We look at the diagram of middle ear. You see, this is the medial wall, this is the lateral wall which has been separated and it has been removed so that we can see the inside of the tympanic cavity or the middle ear cavity. This is the anterior wall, this is the floor of the middle ear cavity, this is the roof, and this is the posterior wall. We have 2 nerves which have the term tympani in them, and we need to understand one is on the lateral wall, the other is on the medial wall. Coda tympani. Coda tympani is on the lateral wall, and tympanic plexus that we can see over the promontory, we can see this tympanic plexus that is present on the medial wall. Anterior wall is related with internal carotid artery, and floor is related to internal jugular vein. This we need to remember, and also we need to remember with this diagram the other important questions. Our roof is formed by tegmen tympani, this is the plate of tegmen tympani which forms the roof, which separated from the cerebral hemisphere. And along with these features, medial wall also presents this round window and oval window. Coming to next question, which nerve lesion could produce the condition where stimulation of right cornea results in blinking of left eye but not the right eye? That means we have contralateral blink intact but ipsilateral blink absent. So to understand this, we need to understand the basic anatomy of the blinking. This is a reflex procedure where afferent is coming through the trigeminal nerve. Afferent is trigeminal nerve, basically the ophthalmic nerve of the trigeminal, and efferent is the facial, which will supply the orbicularis oculi and facial nerve. The afferent brings the information to both side efferent. So this fifth nerve of this side, it will give the information to seventh nerve, and this will mediate the blinking. Now what are the possible outcomes if there is normal fifth nerve and normal seventh nerve? What do we observe? We observe that ipsilateral blink is present, and of course contralateral blink is also present. If there is seventh nerve lesion, then ipsilateral blink will be absent because that side orbicularis oculi could not be contracted, and contralateral is present because the contralateral seventh nerve is working. It will bring the blink reflex. And if there is lesion in the fifth nerve, now afferent is gone. If afferent is gone, there is no question of ipsilateral and contralateral, it will be absent. So coming to our question is asking about the right cornea stimulation results in blinking of left eye but not right eye. So right eye it is absent and left eye it is present. So right sided facial nerve is gone. Next question is atrophy of intrinsic muscles of hand, sensory deficit on medial side of forearm and hand, and diminished radial pulse on turning the head on affected side could be due to, and the options are carpal tunnel syndrome, cervical rib, enlarged axillary lymph node, supracondylar fracture of the humerus. Now we discuss the options separately. Carpal tunnel syndrome will result in median nerve injury, and you see in atrophy of intrinsic muscles of hand and sensory deficit on the medial side, it doesn't fit with the median nerve injury. Coming to next option, cervical rib. Now cervical rib, it is a clinically significant situation if present because they compress the spinal nerve C8 and T1, that is the lower trunk of brachial plexus. So intrinsic muscles of hand are also supplied by this. So intrinsic muscle, there will be atrophy of intrinsic muscles if the C8 and T1 is blocked because of cervical rib presence, and sensory deficit on the medial arm, medial side of the forearm and hand can also be explained by the cervical rib, and they can also compress the subclavian artery because subclavian artery is compressed. Subclavian artery at the entrance into the axilla, it will become axillary artery, which will form the which will divide into radial and subclavian will continue as axillary, it will continue as brachial, and brachial will form radial and ulnar artery. So if the subclavian itself is blocked, so all throughout the blood supply will be reduced, so there will be diminished radial pulse. So all these features can be attributed to cervical rib. This seems to be correct answer. Next option, enlarged axillary lymph nodes. Enlarged axillary lymph nodes, they may present but they are not specifically associated with lower trunk of brachial plexus or the subclavian artery. They can block, if they are enlarged they may block one or two structures, but cervical rib specifically, it may affect this lower trunk most oftenly and subclavian artery. So the given clinical presentation, cervical rib is the best possible answer. Coming to next question, fibular collateral ligament is continuation of peroneus longus, biceps femoris, semimembranosus and adductor magnus. So in this question, peroneus longus is the correct answer. That is a straightforward question, that peroneus longus degenerated part is fibular collateral ligament. Regarding biceps femoris, long head of biceps femoris degenerated part is represented by sacrotuberous ligament. Adductor magnus is the tibial collateral ligament or medial collateral ligament. For the semimembranosus degenerated part, or you can say this oblique popliteal ligament is the continuation. Oblique popliteal ligament, this is the continuation of semimembranosus muscle. So these are different ligaments which are associated with these muscles. So answer to correct answer to the question is peroneus longus. This question is the visual and it asking about the identify the muscle, and we know this is posterior cricoarytenoid. This muscle is posterior cricoarytenoid, and posterior cricoarytenoid is the only abductor. So who is adductor then? Adductors are thyro, inter and lateral cricoarytenoid. That means thyroarytenoid, interarytenoid and lateral cricoarytenoid. Mnemonic is Tilka. Next question is 31-year-old woman complains of headache and dizziness after hitting a kitchen cabinet door with her head. Her MRI scan and venogram show a large blood clot in great cerebral vein of Galen, and the question asks that obstructed vein of the brain is direct tributary of which of the following venous structure. So basically any cerebral vein or the veins of the brain are direct tributaries of dural venous sinuses. So the correct answer to this question is dural venous sinuses. What is emissary vein? Emissary vein, it connects the dural venous sinus. It connects the dural venous sinuses with veins of scalp. Pterygoid venous plexus is again, it communicates with the cavernous sinus through emissary. It communicates to the cavernous sinus through emissary. Diploid vein, these are the veins which lie in the diploe of skull. They lie in diploe of skull. Moving to next question. 43-year-old man has new onset of difficulty with speaking. Examination reveals problems in elevating the hyoid bone and floor of mouth, secondary to paralysis of the posterior belly of the digastric muscle. So the already diagnosis is given that there is paralysis of the posterior belly of digastric muscle, and the question is asking about the nerve supply, which is most likely so indirectly they are asking about the nerve supply of posterior belly of digastric. It is a straightforward question and the answer is facial nerve. We know that posterior belly of digastric, it arises from second arch and supplied by facial nerve, which is the nerve of second arch. Now ANSA is quite interesting. Choice was given here. ANSA, it supplies all infrahyoid muscles. except thyrohyoid. What are infrahyoid muscles? You can remember by applying this mnemonic: omohyoid, sternohyoid, thyrohyoid, and sternothyroid. All are supplied by ANSA except thyrohyoid. Now moving to next question. Clitoris develops from genital tubercle, genital fold, labioscrotal swelling, or urogenital sinus. So we need to understand basic thing when we are dealing with such kind of questions. You see, we have genital swellings, okay, genital tubercle, genital fold. In male and in female, they are going to give rise to different structures. In male, genital swelling will form the scrotum. In female, labia majora. Genital tubercle will form the penis part, glans or the penis part. Clitoris in female is formed by the genital tubercle. The genital fold will form the ventral aspect of penis. And in females it is going to form the labia minor. And we have genital ridge, which will form the testis in male and ovary in female. Now the question is asking about the clitoris, so it develops from genital tubercle, so option A is correct. Next question. Medial meniscus is more prone to injury because it is semilunar, it is attached firmly to tibial collateral ligament. Third is it is avascular. Fourth is connected to lateral meniscus by a lateral ligament. Actually, this is a statement that medial meniscus is more prone to injury because it is attached firmly to tibial collateral ligament. It is not only attached firmly to tibial collateral ligament but also to the capsule of joint. Also to capsule of joint. And lateral meniscus is separated from the capsule by the tendon of popliteus muscle. What happens during any forceful movement? Medial meniscus, which is attached to tibial collateral ligament and capsule of the joint, it gets crushed between these two structures. But lateral meniscus, as it is kept away from the capsule by the tendon of popliteus, it has less chance for injury. So medial meniscus is more prone to injury because of its firm attachment to tibial collateral ligament and also to the capsule of knee joint. 11th question. Carpal tunnel syndrome, which of the following occurs? Loss of sensation over thinner eminence, flexor digitorum superficialis paralysis, flexor pollicis brevis paralysis, adductor pollicis paralysis. Now carpal tunnel syndrome, median nerve is injured, but we need to understand that this is flexor retinaculum. When the nerve is coming under the flexor retinaculum, it gives one branch that passes above flexor retinaculum, that is palmar cutaneous branch. This palmar cutaneous branch will be intact even median nerve is compressed in the carpal tunnel syndrome, so loss of sensation over thinner eminence will not be seen. Now flexor digitorum superficialis is supplied by a median nerve within the forearm, so its paralysis has nothing to do with the carpal tunnel syndrome. flexor pollicis brevis paralysis will be seen because median nerve is going to supply after passing through the carpal tunnel. So if it is compressed in the carpal tunnel, it will not be able to supply flexor pollicis brevis. Regarding adductor pollicis, it is supplied by ulnar nerve, so its paralysis will not be seen. Next question is the visual question, that portal vein develops from which of these structures. Moving to next question, portal vein develops from which of these structure, and this diagram was given. Now we have to see in this diagram, this A is showing the common cardinal vein, B is showing the left umbilical vein, and this is right umbilical vein D, C is the right vitelline vein, and we know that portal vein develops from the vitelline vein, so answer in this question will be C. So the correct answer is C. Next question is, in this diagram shown below, what is true about the structures piercing clavipectoral fascia? A is thoracoacromial trunk, B cephalic vein, lateral pectoral nerve. B choice, thoracoacromial trunk, basilic vein, lateral pectoral nerve. C choice, lateral thoracic artery, basilic vein, lateral thoracic nerve. D choice, lateral thoracic artery, cephalic vein, and lateral pectoral nerve. We know that structures piercing clavipectoral fascia are, they can be remembered by the mnemonic call C for cephalic vein, A is acromiothoracic or thoracoacromial artery, L is lateral pectoral nerve, next L is lymphatics from the breast which are going to the axillary lymph nodes. So the correct answer to our question is A, where A is thoracoacromial trunk, B is cephalic vein, and C is lateral pectoral nerve. Cell next question is, the cell lining of common bile duct. Options are stratified columnar, stratified squamous, simple cuboidal, and simple columnar. Answer is straightforward, D, simple columnar. We know that intrahepatic ducts, cystic duct, and common bile duct, they are lined by tall columnar epithelium. Last question is, respiratory bronchiole proceed into, choices are terminal bronchiole, bronchi, tertiary bronchiole, and alveolar duct. We see this diagram and we understand that trachea bifurcates into principal bronchi, which further divide into various secondary, tertiary bronchus, and they keep on dividing into number of generation of this bronchus, and ultimately they form the bronchiole. This difference between bronchus and bronchiole is, one difference is bronchiole is having the diameter smaller than 1 millimeter. Bronchiole is smaller than 1 millimeter. The other thing is, as it is decreasing in diameter from trachea to bronchiole, the amount of cartilage is decreasing. Amount of cartilage is decreasing, and amount of smooth muscle is increasing within the wall. And at the level of bronchiole, when we reach the bronchiole from bronchus, cartilage is absent. And the wall is made up of muscle only. This is the bronchiole. But then from terminal bronchus, it divides into the lobar bronchiole, which further divides into terminal bronchiole, and the last in this bronchiole series is the respiratory bronchiole, because it will continue into alveolar duct, and that is what our question was asking. And alveolar duct leads to atrium. In the atrium we have alveolar sac and the alveoli. So this is the respiratory portion where actual exchange of the gases will take place, and whole series of these tubes, this was conducting portion from trachea to terminal bronchiole. From respiratory bronchiole onward, this is the respiratory portion. So the answer to our question is respiratory bronchiole proceed into, answer will be D, alveolar duct.